Hi, welcome back to NurseEdScholar. So if you have a patient that's short of breath, how do you know if the problem is an oxygenation problem or a ventilation problem? Because here's the truth, not all, respiratory problems are treated the same way. Some patients need oxygen. Other patients need help removing carbon dioxide. And if you choose the wrong intervention, your patient can deteriorate quickly. On the NCLEX, this distinction is one of the most important decision points. So in this lesson, I'm going to show you how to quickly recognize a patient with a rising CO2 levels, respiratory fatigue, decreased level of consciousness, and hypoventilation, and how you determine, whether the patient is experiencing oxygenation failure or a ventilatory failure. So let's start. Okay, so with respiratory failure, it can be divided into kind of two main types: oxygenation failure and ventilatory failure. And, that's basically what we're going to talk about in today's lesson. Now, when you're looking at oxygenation failure, this occurs when the lungs cannot effectively move oxygen into the bloodstream. The problem is just oxygen is not getting in, right? And the common causes could be your patient could have pneumonia, they can have pulmonary edema, they can have acute respiratory distress syndrome, they could have atelectasis. So now let's look at ventilatory. Now, when a patient is exhibiting ventilatory failure, remember this happens when the body can't remove carbon dioxide effectively. The problem is CO2 is not getting out of your patient. And common causes for this is COPD, drug overdose, neuromuscular weakness, patients with neuromuscular weakness, think of, they just can't get those lungs to expand. Maybe the diaphragm is not, effectively working. And respiratory failure, that's right. And, understanding which problem is occurring determines the correct intervention. Okay. Now, let's go back to oxygenation failure. Okay. This is usually easy for students to recognize because the signs are pretty obvious. Your patient's going to exhibit a low oxygen saturation, so you're going to put that pulse ox on them. Tachypnea, they're going to be breathing fast. They may be restless. They may seem agitated. They may be anxious. You may see them using accessory muscles. And in severe cases, you'll see some cyanosis. You know, Remember, in oxygenation failure, patients, are often really working hard to breathe, and their bodies are trying to compensate for those low oxygen levels. Okay, so let's look at the other one. Now, with ventilatory failure, it's really more dangerous than oxygenation failure because it's often missed, pretty early. Instead of your patient looking restless and anxious like in oxygenation failure, they'll be tired, drowsy, maybe difficult to arouse, confused, less responsive. And that is because those CO2, that dioxide levels, are rising. So let's look at the effects of carbon dioxide, rising. Now, when your CO2 levels increase, your patient may develop headache, confusion, that change in their level of consciousness, they drowsy, um, and this is because of a condition called um, CO2 narcosis, so carbon dioxide narcosis. And then there's something called respiratory fatigue, and this is pretty critical. Early in respiratory distress, patients are just breathing rapidly, right? But think about it, over time, their muscles are going to tire out. And so signs of fatigue that you really need to watch on your patient is going to be a slowing of their respiratory rate. They may start to breathe shallow. They just have a decreased effort of just breathing altogether. And they'll be unable to maintain ventilation. And this is really a dangerous sign because, like we said, if you don't breathe and get that CO2 out, those CO2 levels are going to start to rise. And the tricky thing with this is that, you're going to look at your patient and say, oh, some nurses may be like, well, Mr. Jones, he looks better because he seems calmer. But in actuality, the patient could be failing. And so that's why you're really going to have to make sure that you are, assessing your patient regularly, especially if they have any kind of respiratory condition. Now, hypoventilation. We talked about CO2 levels. This is very dangerous. Now hypoventilation, if you don't know, that means that the patient is not breathing effectively enough to remove that CO2, that carbon dioxide. And what you're going to really want to watch for your patient would be, I've said this before, slow respiratory rate, right? Shallow respirations, decreased level of consciousness. And then you're going to watch for those rising CO2 levels. And like, how am I going to know that? Your ABGs. The doctor is more than likely going to, get an order for some ABGs. And so it's important for you to also look at and interpret those lab results as well. And, the type of patients that you're going to see this hypoventilation is in those who have COPD, sedated patients, um, opioid overdose patients because they're going to start that, we always talk about their respiratory rate is going to drop because they're overly sedated with that, the opioid overdose, and neuromuscular disorders. Because these patients, they may not appear distressed, but they are at risk and high risk for respiratory arrest. Okay. So you have to remember that. Remember, what conditions would cause, your patient to actually retain carbon dioxide. Now, you know, when you're looking at the NCLEX or you're, looking at test questions, you need to ask yourself a question, or several questions. Is this an oxygenation failure? You're going to look for low SpO2. What's your oxygen saturation? Is my patient agitated? Do I see tachypnea? Is there visible distress? Okay. And if so, if this is an oxygenation failure, you're going to give your patient oxygen, right? Now, if it's a ventilation problem, you're going to look for decreased level of consciousness, fatigue, because they've been breathing so hard, they're tiring out, shallow breathing, slow respirations. And with this, think of slow respirations, increased CO2 levels. So, what's your intervention going to be? You're going to be looking for orders for ventilatory support, maybe a BiPAP machine, or the patient may actually need mechanical ventilation. They may need to be intubated. And then lastly, as you're assessing your patient, is my patient improving or are they deteriorating? You have to look at trends. I've said before, look at the trends on your patient. If your patient goes from really anxious and restless to calm, you have to really assess your patient. If they're tachypnic and they're just breathing hard, trying to get that oxygen in, and now their breathing has slowed, you have to watch that because they may not actually be improving. They may actually be failing. And that is why it's so important that we keep an eye on our patients and constantly assess our patients. Now let's look at a quick scenario. Okay. A nurse is taking care of two patients, right? So your first patient, they have pneumonia. Respiratory rate 32, their SpO2 is 85. You're like, oh, 85, right? They're anxious and they're restless. Your second patient, she's taking care of a patient with COPD. Their oxygen saturation is 91%. Their respiratory rate is 10, but they're drowsy and they're difficult to arouse. Okay. Now, which patient would be most concerning? A lot of students, if they're rushing and not really thinking through, they're going to pick A because they're going to focus on that 85% SpO2, right? But your patient B is actually, you know, um, in a more dangerous state. And that's because they're hypoventilating. Look at that respiratory rate of 10. That means they're going to start retaining CO2 because they're just not blowing it off. They're going to have that CO2 retention, and they're going to have a decreased level of consciousness. As the CO2 levels increase, your patient's going to become more confused. And that is something serious. This indicates ventilatory failure, which can quickly lead to respiratory arrest. So you really, when you're looking at the stem of your questions, and you really have to say, okay, what is the most important thing in here? What can cause the worst outcome in my patient right now? And so when we look at questions like this, why do students miss questions, right? Students often associate distress with severity. Oh, they have to look like they're in distress, right? And that means that they're worse. But in actuality, you know, that calm patient may be the sickest, not the one that's most anxious. Um, and that's the biggest thing. Calm is not necessarily stable. Calm can be actually something serious. Person distressed may not be, the severest patient. If you're looking at which patient am I prioritizing to see first, you got to look at the trends. You have to look at the labs. You have to keep assessing your patient, right? Because, the big problem is that if they become drowsy, if they become quiet, if they look like they're losing their respiratory effort, these are signs of failure, not improvement. So remember, an oxygenation failure is an oxygen problem. A ventilatory failure is a CO2 problem. So when you're having your patients, I'm gonna say it again, you always want to assess their oxygen saturation, their respiratory effort, their mental status, and look at those trends over time. Because recognizing the difference can truly save your patient's life. Remember that. So that's it. So if this lesson helps you understand respiratory decision making, hopefully it made it more clear. And please like the video. Please subscribe to Nurse Ed Scholar. This series is designed to help you think through clinical situations like, the NCLEX expects you to. So if you want some more structured practice, check in the clinical judgment workbook that's in the link below. In my next lesson, I'm going to talk about respiratory deterioration, trying to bring things together, early versus late signs. This is really tested, and sometimes, a missed topic in nursing school. So I'll see you next time in the next lesson. Happy studying from Nurse Ed Scholar.